So today we're going to give you a series of tips for how to advocate for the most appropriate, collaborative, empowering experiences possible using the CANs in treatment planning. Right. All right, experiences of treatment planning. So let's get into what people have actually experienced. It's like about half of the time, the CFT Child and Family Team or therapist gave you a copy of your child or youth's goals. Note that that's something that's going to be absolutely essential as you move forward, is asking for and getting that, because that's the basis for identifying what to do next. Did the child and family team or therapist help your youth choose a small number of the highest priority needs to focus on? That's going to be important. We have about 40% of folks who agreed with that, and about 50% of folks who disagreed or strongly agreed with that. That's important because we have to be able to identify just a couple of things that we work on. Otherwise, our efforts are going to be spread too thin, right, across all the things that we're trying to do. Did they help you set goals that were realistic? About half of folks, or just more than half of folks, agreed with that. And we're going to talk about what realistic means. Part of realistic is really thinking about how much effort you have to put in to be able to achieve that goal, and to achieve that goal within the next 90 days, right? So these should be time-limited goals. Did they write them in your words or your youth or child's words? Only about half the time, or slightly less than half the time, do people agree that was happening. It's really critical for the goals to be written in your words so that you can really own them, right? So that they mean something to you. And so it's not just something somebody else is forcing on you. Did they come up with ideas and strategies that were tied to the strengths of your child and family? And we have almost 60% of folks who agreed that that they did that. And about 40% who said no. We'll talk a bit about how strengths are absolutely critical to being able to meet your goals and to improve functioning over time. Strengths are really the cornerstone of being able to move forward from some of the challenges that we have. And building strengths is one of the most overlooked parts of the treatment planning process that we have. They check in often with you to see if therapy was helping you reach your goals. We have the most positive responses here, in that people were, most of the time it looked like, checking in to see if therapy was helping you reach your goals. That's absolutely critical, because treatment should never stand still. It should always be adapted to what's working for you or not working. And then, did they make it easy for you to say when something wasn't working for you or your child? And almost everybody agreed that it was. That's terrific. Okay. So what we have, I think, as you look at the polls, is a pretty mixed bag, in that for most of these practices, you could almost roll the dice. And half the time you get the experiences you wanted, and half the time you get an experience that really wasn't what you wanted. And in fact, that's something, unfortunately, that is all too common. So if we look at other systems in terms of the percentage of parents who indicate that they strongly agree that the professional helped them choose a small number of the highest priority needs to focus on, that's about 58%. When you ask youth the same thing, the numbers drop a little bit on that. In terms of setting goals that were realistic, it's a little less than half. Writing the goals in their own words, or your own words, it's a little less than half. Helping folks understand how the treatment would actually help them, that drops dramatically. And then helping them understand how that would help them and their child, it drops back to about that 50%. Checking in often to see if therapy was helping me reach my goals, about just over a third of folks strongly agreed that was happening. Checked in often to see if therapy, so the top number there, I'm sorry, was youth, and the next one under it was parents. And again, what we can see is that it's more likely that professionals are going to check in with parents than with youth to see if goals are being reached. And it's also more likely that it's going to be easy or easier for parents to say when something wasn't working than it is for the youth themselves to be able to say that. So it's important for parents who are advocates and are involved to be able to know that, you know, sometimes you might actually be the amplifier of your child's experience, and that they may have even more reservations about talking to the therapist about the treatment planning process and about achieving their goals than you're experiencing, right? But in both cases, those are really those experiences are really much less favorable than we would like them to be. They're not happening at the rate that we would hope for. Which brings us to the question that we're going to spend almost the entirety of the rest of our time on, which is how is it then that we bridge that gap? How is it that we move from practices that we know should be happening and we want to have happen, that we know are associated with better outcomes, to them actually being commonplace, to them actually being the experience that nearly every parent and every youth has? Well, one of the first things that we can do is we can identify from providers' perspectives what providers believe should be happening in the treatment planning process. So not only did we talk to families when we were doing this work about what they hoped that the practice would be like, we started talking to supervisors, to therapy supervisors, to understand what it is that they said would be important. And then in Idaho, we also have a look at the treatment planning policies that are in place. So when you think about the policies, and then when you think about what therapists say should be happening, that gives us a real clear sense of, from the provider side, what these practices should be. So let's start and take a couple of minutes and we'll go through Idaho's own treatment planning policies so you know what those are. And then we'll jump into the perspective of providers and what they have indicated is good practice, and then what's not, so that you'll know, even from the provider perspective, when it is that you should be looking to elevate any concerns that you have about the care that you're receiving and about the treatment planning process. So in terms of Idaho's treatment planning processes, these come from the DVH policy 1213, which was instituted in 11/7/2018. There's a whole set of policies there, and they should be accessible to anybody if you dig around on the web long enough. Even though only about half of folks indicated that they were given a copy of the youth's goals, their goals for treatment, it is in policy that the clinician should offer every client, parent, or guardian a copy of the plan. And in fact, all people who participated in the development of that plan are supposed to sign it. Whether or not you receive that treatment plan should also be documented. So you really, there really shouldn't be an instance in which you're not explicitly offered a copy of the plan. So if that doesn't happen, you need to ask for that plan. If the person doesn't provide it or for some reason refuses to provide it, then please go up the chain at that agency. That should really be an extraordinarily rare occurrence. So the treatment plan, a copy should be automatically offered to you with clearly defined goals, objectives, and interventions when it is completed. So you should both be asked to sign it, and then you should be given a copy of it. In terms of the timelines for completing these plans, 15 days from the date that you've been determined eligible for services, a treatment plan should be completed. That is a tight timeline, but it lets you know that that should be happening almost immediately. So the moment you're determined eligible for services, that provider should be working with you to identify what your goals are, what your child's goals are, and how to achieve those. Now that's 15 calendar days, right? That's not business days. That's not, if we made it business days, it was pushed out to 3 weeks. It's really 2 weeks from the date of the eligibility determination or the date that the court orders treatment services. And then there are 2 other pieces here that are really critical. The policy indicates that there should be 120-day reviews of that treatment plan every 120 days. So every 3 to 4 months, there should be a formal review of that treatment plan. And that is really your opportunity to say these goals are reasonable or unreasonable, or they've already been accomplished. These services are appropriate or inappropriate or no longer match the goals. It also should coincide roughly with when your CANS is updated. So the CANS should be updated. You should see from the CANS, what are the things that you've made progress on? What are the things that need to be addressed now? And then that should translate into the services and the goals that it just says services are called interventions and the goals are typically called objectives on the treatment plan. So you should be getting an opportunity fairly frequently to review how care is working and then to update it. From the get-go, as an advocate, really identifying the moment that first treatment plan is put together and signed off and that you get a copy of it, identifying when the next review will be is really important because that puts the therapist on notice that you want that to be a formal process. You don't want them to simply be looking at the treatment plan after they've completed a session, updating it, and then writing a note that says, oh, there are no changes that need to happen, et cetera, et cetera. You want to make this a process where you're really involved in reviewing that treatment plan, seeing if it still makes sense, seeing if the services are still appropriate, and then updating the things that need to be updated. Otherwise, what happens is you end up getting stuck waiting until this annual renewal of the treatment plan to make substantive changes. So you want to be in on those 120-day reviews. In terms of the implications here, there are a couple of things that are important to keep in mind. One is that if the CANS is an assessment and identifies what are the needs and strengths that need to be acted on, and so the CANS should be completed before any treatment plan update happens, and that lets you see what progress has been made and what things you still need to work on, or what new things have come up that need to be addressed. The other thing that's very interesting here is that psychological treatments, interventions have their greatest effects, about 50 years of research indicating this, within 12 to 16 sessions. That coincides very neatly with 120 days out, right? If you're getting care weekly. So you should be feeling the effects of treatment in terms of improved functioning and reduced symptoms also, and new strengths being developed at that 120-day review. If you're not really experiencing a substantive change there, then something needs to be shifted in terms of the care that you're receiving. So it is important to note that review period really coincides with what the research says the time that it should be taking to be able to feel the effects of care. Right? So those things should be lining up. All right. So goals, this is part of the DBH policy. So their goals, the goal is the broad general statement that expresses what it is that you hope is going to change. It's the overall outcome that you hope to accomplish or change. So really you'd think about this as the thing that you want to accomplish through treatment. what is the functional change that you would like to see occur as a result of treatment, right? And it should be written in positive, they say call it client-centered, which means I statement language, indicating what the youth and or family would like to see happen as a result of care. Now, the nitty-gritty here is this next step. This next step is objectives. So objectives are the incremental short-term changes that are stated in action words. Those objectives should clearly be the things that move you towards the goal. So you might think about objectives as the things that should be accomplished within that 120 days that are going to get you close, clearly closer, measurably closer towards the goal that you're hoping to get to, right? Objectives are supposed to be written in SMART terms. So they've defined SMART here in policy as simple, measurable, that means there should be numbers associated with them, attainable, reasonable, and time limited. What most folks do is they set 1-year timelines for the objectives because that's the farthest out that you can go without changing the documentation on your treatment plan. I don't think anybody actually, as a parent or a youth in care, wants to wait a year to see change, right? So if you're advocating for effective care, what you really want to advocate for is that each of these objectives are written in 120-day increments so that the therapist is really thinking, what will I achieve before that 120-day review working with you? And that really helps keep people focused on what it is that they're trying to do in those 12 or 16 sessions where you should be experiencing change in the most profound way. When they say that the objectives should be measurable and achievable, measurable, you typically look for how frequently is it happening now, and how frequently would we hope it to happen at the end of the time period that we're working on this. So today, how many times a week does it happen? Or how many times a day does it happen? A behavior that we don't want to have happen, or a behavior that we're hoping to build on. And then in 120 days, what would we like to see that frequency be? By achievable, what you're really looking for is the effort that we're putting into this consistent with what it's going to take to change it in 120 days? So is meeting once a week or once every other week, or 2 times a week, or getting very intensive treatment? What's actually required to move the needle on this? And that's why frequent check-ins with the therapist are important, because you really can start to say, well, you know, we're meeting this often and it doesn't feel like anything's changing, or we're meeting this often and yeah, it really is working. Let's keep this up, right? So that achievable is really talking about, for how much effort in, what are we getting out of it? All right. And I've talked a bit about this. So objectives are the short-term goals you should be able to accomplish by your next treatment plan review. If it can't be accomplished in 90 to 120 days, then it really shouldn't be on that plan. You should really push for these to be things that can be accomplished in 90 to 120 days. It should be really clear how those objectives and meeting the objectives naturally lead to the accomplishment of the big goal. Right? Should be very easy to see that. And if those things aren't easy to see, then the therapist you need to be advocating for the therapist to really work to write objectives that show what are the stepping stones towards meeting that larger goal. This is where rubber meets the road in terms of treatment planning. So interventions. or plan services. These are the activities that the team, particularly the therapist, and anybody else that they have involved in care, provide to help the client achieve their goals and objectives. The intervention, as they describe it in the treatment plan, should include these elements: the program name, so the program is going to provide it, what type of service it is, how frequently it's going to be provided, who is it that actually is going to provide it, where they're going to provide it, and how it will be completed. That is really getting clarity around that is going to be helpful to you, because then you can say, you know what, we're getting this, once a week. It's written out in the service, in the plan as are being able to get it once a week. And that's really not the frequency that's working for us at the 90 to 120 day review. Or in the plan, it says we'll get this once a week, and yet we're only getting it every second or third week. It's not coming through for us for some reason. We have to figure out what's a way to get it more frequently, right? Having things down on that treatment plan is absolutely critical to being able to advocate for appropriate care. So this interventions piece is a big part of kind of the heart and soul of what you can advocate for in terms of getting appropriate care for your child or family. Right now, in Idaho, there's a continuum of care gap. So there are services at the very highest level of intensity. There are services that are traditional outpatient weekly sessions, or bi-weekly sessions even is more frequent. But intensity in the middle there, that it might be when you need services 2 or 3 times a week for your youth, things like that. Those are very infrequently provided right now. So being able to indicate that a frequency of service is not working for you, it's not helping you or your child meet their goals, is really important to help them push the system along in terms of developing those more intensive services, authorizing those more intensive services, and getting what you might need for your youth or family. And really having that on that treatment plan document is critical. The timeframes, those expected achievement dates for objectives or overall goals can't be later than 12 months, but you should really be pressing for the objectives to be written in those 90 to 120 day increments, as opposed to 12-month increments. Otherwise, there's no accountability in the meantime.
Thank you. Okay, that's great. Then at the very beginning of your talk, where you were citing, or early in the talk, DBH policies.
Yeah.
The 1213, as I remember. The question came up, but are private providers bound by these policies of DBH, which we were able to answer, no, they are not. But we wondered if you could comment on that. We further shared some information when asked whether Optum had a crosswalk to match between the DBH policies and their services. And we do not know the exact answer to that, though we provided some information on the clinical guidelines that Optum does have, and that we know that their contract, and we have Optum members with us today who could pipe into the chat, their contract does, of course, require them to create services that adhere to the DBH policies. But kind of to that issue of, but then you have a private provider actually doing these services. And so what happens when a parent feels caught between the fact that that provider is not adhering to the policy or intention of the service?
Absolutely. Yep, that's a huge problem. And in fact, if I were going to be quite dour and pessimistic, I would say that it many times appears that systems are designed to keep people from being accountable. And the more structures you put in place, the easier it is to avoid accountability. Now, there is actually a very clear way to move away from that, and that is to publicly and transparently indicate what your timeline standards are for every process and care, and what the expected performance is around that, and to put that in contract language. And that's one thing that we keep recommending to every state that we work with. In fact, some states have done a good job of that. Some counties or regions, when they do that. So part of right now people are stuck going up multiple different chains where it's unclear who ultimately is accountable for it. But I will say the structure of things per Medicaid federally, Medicaid says that the state is responsible for care. It doesn't matter who they contract it out to. So the state is ultimately the one who is responsible. So if providers are consistently providing care that is not consistent with policies that are put in place by the state is the one who's ultimately responsible for that, even if they contract it out. So I would keep that in mind in terms of the formal way that gets run up the chain and how the state addresses that. That tends to be a state-by-state process. And I want to be careful because I don't have expertise around the complaints process in Idaho. Although you should also note that one of the things that they indicated in the remedy to their lawsuit is that they would clarify the complaints process. So what you can ask any agency is, if you have a problem with services, what's your complaints process? And they need to have that in place and be able to provide that to you. And that should provide you actually with a line to the state